In this video, we'll be looking at the diagnosis of Cushing syndrome. So mainly I'll be concentrating on the laboratory diagnosis, how laboratory diagnosis is established. Now this picture will give you an outline of what is controlled by the adrenal medulla and what is controlled by the adrenal cortex. We know that ACTH, the adrenocorticotropic hormone, mainly controls the adrenal gland. Now, in pathological states, there may be either increase in the ACTH from the pituitary or ACTH can come from an ectopic source. So that is one possibility. Another possibility is that the adrenal gland itself will start to hypersecrete. So these are the broad two things you should be aware when you think about the diagnosis of Cushing's syndrome. Now, adrenal cortex is mainly related to the control of renin-angiotensin aldosterone axis, and adrenal medulla mainly controls the blood vessels vascular tone and also insulin resistance. So broadly speaking, it is sufficient if you remember this for all practical purposes with reference to the cellular effects the abnormality can produce. Now, when you have a clinical feature suggestive of Cushing syndrome, you think of two things. Either it can be ACTH dependent, as I already told, or it can be non-ACTH dependent. Now, you can see that 80% is ACTH dependent. And of these, pituitary adenoma secreting ACTH forms 70%. So, close to two-thirds or more than two-thirds of all Cushing syndrome, if you have ruled out the steroid intake. So, I am not bringing in the steroid intake here. It is coming from the pituitary. So the remaining 10% will be ectopic ACTH. As I told you, ACTH coming from source other than the pituitary. So in clinical practice, small cell lung CA is the most common things we see. Others are very challenging to diagnose. When the cause of ectopic ACTH is not small cell lung CA, then it's really a challenge in clinical practice to identify where from the ACTH is being secreted. Now, non-ACTH forms the remaining 20%, and of that, adrenal adenoma is more common, but this I would say is little variable now with more and more diagnostic availability for reason for malignancy. Adrenal carcinoma is equally prevalent. We have seen adrenal carcinoma in unusual diseases like lymphoma, and outside the lung bronchogenic carcinoma also we frequently see. So non-ACTH dependent, you need to think about the adrenal source. Either it can be adenoma or it can be adrenal carcinoma. Adrenal carcinoma is something which is difficult to identify. Close slices may miss it, and with the advent of PET CT scan, we are able to identify malignancies which were thought to be really occult or unknown primary. Now, three situations can mimic the biochemical aspect. One is alcohol excess, major depressive illness, and obesity. So this is quite challenging because as you can see there, the biochemical features are very much similar. So I'm not going into that now. So let's see, once you have a suspicion of Cushing syndrome, how to go about. So first, as I told you, you need to exclude exogenous glucocorticoid exposure. This is very important. In the history, it may be occult. The patient may be taking it through some food products or some physical building measures, supplements. So this we need to properly obtain from the patient by history. Now you can select one of the three, but in practice, we use the dexamethasone suppression test. So this can be a overnight dexamethasone suppression test, or it can be a low dose dexamethasone suppression test, wherein the dexamethasone is given for 2 days or 48 hours, whereas in overnight it's a single dose. In overnight dexamethasone suppression test, we give 1 milligram of dexamethasone usually at 11 p.m. before retiring to bed, and the cortisol level is checked at 9 a.m. in the morning. In low dose dexamethasone suppression test, zero point 0.5 milligram of oral dexamethasone is given 4 times daily. So that is 2 milligram in 24 hours, and then another zero point 0.5 milligram 4 times daily next 24 hours. So 48 hours is given, and then the serum cortisol is tested. And if the value is more than 50 nanomoles per liter or 1.8 picogram, then it indicates that you are handling a patient with Cushing syndrome. So here, as I already told you, we are taking out these two. So you are looking at basically here. Now here what you do is, let's block the mid segment thing which appears confusing. So for all practical purposes, if the overnight dexamethasone suppression test or low dose dexamethasone suppression test is abnormal, you think about Cushing's syndrome, right? So that's a very simple way of looking at it. So now we need to go about and look for reason for the Cushing syndrome. So as I've already told, it can be ACTH dependent or non-ACTH dependent. So you can measure the plasma ACTH. When it is more than 3.3 picomole, it indicates it is ACTH dependent. The etiology already I have told. So ACTH dependent can arise from the pituitary or extra pituitary source. Now if it is less than 1.1, it is ACTH independent. But remember, now ACTH alone may not be the, many times you will have an intermediate value between 3.3 and 1.1. So in the imaging, the era of imaging, we use imaging to identify it. So we know that ACTH dependent are these and non-ACTH dependent are these. So what we do is that imaging is used, and advanced additional testings are used for the diagnosis of carcinoid, especially the PET-based positron emission tomography based investigations are helping us a lot to identify ectopic ACTH secretion, and even carcinomas are very occult, very small in the adrenal gland. So you always utilize the additional imaging modality to differentiate between ACTH dependent and non-ACTH dependent, not necessarily always based on the absolute ACTH level, when especially when it is in the intermediate value. So I think I have given you an idea about how a laboratory approach of diagnosis of Cushing syndrome and how to differentiate it from Cushing's disease. So Cushing disease is basically the pituitary adenoma which is secreting the ACTH. So I think this is a little simplified approach for the diagnostic aspect. For additional reading, you may refer to Harrison's internal medicine textbook, where certain more additional information and intricacies, especially when to test it, like when a patient is on estrogen, it has to be stopped for a period of 6 weeks. And there are a few other things which you should remember, especially in this category, which I told, obese individual. It is quite challenging to really suspect and diagnose, because you will have biochemical features also sometimes, but often mild. So, hope you understood the concept.